Good afternoon. I am Dr. Anil Kumar, Head of Department of Pediatrics, Government Medical College Bettiah. I welcome you all in this online teaching program. And today I am going to discuss on a very important topic, that is thalassemia, a very important entity in the chapter of hemolytic anemia. There are different names of thalassemia, also called Bone-Jackson anemia, Coolidge anemia. This thalassemia is made of the Greek words in which the thalassa means sea, emia means blood. This thalassemia is first observed around the Mediterranean Sea. In this world map, the area colored in orange is thalassemic region. Now we shall define thalassemia. Thalassemia syndromes are a heterogeneous group of inherited anemias characterized by reduced or absent synthesis of either alpha or beta globin chains of HbA. Here we can see the hemoglobin molecule in which there are alpha chain, iron, beta chain and heme group. This picture showing a structure of hemoglobin. Hemoglobin is a spherical molecule consisting of 4 peptide subunits, globins in the form of a tetramer. Hemoglobin of adult HbA is a tetramer consisting of 2 alpha and 2 beta globins. Each globin contains one heme group with a central ferrous ion. Hemoglobin consists of two parts, globin 96%, heme 4%. Heme portion is synthesized mainly from acetic acid and glycine in the mitochondria of young RBC. Globin is composed of 4 large polypeptide chains. Globin is synthesized by ribosomes. In the synthesis of globin, the various types of globin combines with heme to form different hemoglobin. 8 functional globin chains arranged into clusters. Beta cluster, beta, gamma, delta and epsilon globin, E genes on the short arm of chromosome 11. Alpha cluster, alpha and zeta globin, Z genes on the short arm of chromosome 16. In synthesis of heme, protoporphyrin ring combines with an iron atom in center. The main site of synthesis is mitochondria, but the mature red cell does not contain mitochondria. 3 major types of hemoglobin and embryonic hemoglobin. In adult HbA consists of 2 alpha and 2 beta chains forming a tetramer. It is about 97%. In postnatal life, HbA replaces HbF by 6 months. In fetal hemoglobin, HbF consists of 2 alpha and 2 gamma chains, 1% of adult hemoglobin. 70 to 90% at term, falls to 25% by 1 month and progressively. In HbA2 consists of 2 alpha and 2 delta genes. It is about 1.5 to 3% of adult hemoglobin. In embryonic hemoglobin, GABA1, GABA2 and Portland. This slide showing the inheritance of thalassemia. The mode of inheritance is autosomal recessive. In beta thalassemia, there is a point mutation on chromosome 11. In alpha thalassemia, there is a gene deletions on chromosome 16. There are two major classifications of thalassemia. If synthesis of alpha chain is suppressed, level of all 3 normal hemoglobin A, 2 alpha 2 beta, A2, 2 alpha 2 delta, F, 2 alpha 2 gamma reduced. This is called alpha thalassemia. If beta chain is suppressed, adult hemoglobin is suppressed, called beta thalassemia. Here, classification of thalassemia type is given in detail. Alpha thalassemia, beta thalassemia, gamma thalassemia, delta thalassemia, delta beta thalassemia, and other types given here. This table showing the genetic classification of beta thalassemia. In beta thalassemia minor oblique trait, beta oblique beta plus, beta oblique beta 0 genotypes. The clinical severity will be silent. In beta thalassemia intermedia, beta plus oblique beta plus or beta plus oblique beta 0. The clinical severity will be moderate. Beta thalassemia major, beta 0 oblique beta 0. The clinical severity will be severe. Here is the genetic classification of alpha thalassemia, in which there are different types of gene presentation with its genotypes and clinical classifications. Now we shall discuss about the pathophysiology of thalassemia. This slide showing the diagrammatical representation of bilirubin metabolism. Here we can see the breakdown of hemoglobin with the different steps in the formation and fate of bilirubin. If we will go through the pathophysiology of the beta thalassemia, since the beta chain synthesis is reduced, so there is a excessive production of HbF and HbA2 and reduced production of HbA. The relative excess of alpha chains forms the alpha tetramers. This forms the aggregates which precipitate in the red cells and forms the inclusion bodies. These inclusion bodies cause premature destruction of maturing erythroblast within the marrow. This is called ineffective erythropoiesis. If this destruction occurs in the periphery, and this is called hemolysis, this ultimately result into the anemia. This anemia is due to the lack of adequate HbA. This will cause tissue hypoxia. There will be increased erythropoietin production. There will be increased erythropoiesis in the marrow and sometimes extramedullary. This extramedullary erythropoiesis will cause expansion of the medullary cavity of various bones. There will be also liver and spleen enlargement due to the extramedullary hematopoiesis. This slide showing the effects of marrow expansion. There will be pathological fracture due to the cortical thinning. There will be deformity of skull and face, sinus and medullary infection due to ineffective drainage. There will be folate deficiency. There will be hypermetabolic states in the form of fever, wasting. There will be increased absorption of iron from intestine. Here, hepatomegaly is caused by extramedullary erythropoiesis. Iron released from breakdown of endogenous or transfused RBC. If it is not utilized for hemoglobin synthesis, there will be hemosiderosis. This will also cause hemochromatosis. The infection of hepatitis B, C, and HIV is due to the multiple blood transfusion. There may be also possibilities of chronic active hepatitis. Here, splenomegaly is also caused by extramedullary hematopoiesis. Because there is a constant hemolysis in the spleen, so there will be work hypertrophy of a spleen. The progressive splenomegaly will lead to hypersplenism. Jaundice is also an important feature of thalassemia. Because of the continuous hemolysis, there will be unconjugated hyperbilirubinemia. The transfusion will lead to the hepatitis and hemochromatosis also. There will be obstructive jaundice due to the GB stone and cholangitis also. Different causes of infections in thalassemia are given below. This is due to the increased iron in body. There will be blockage of monocyte macrophage system. Due to the hypersplenism, there will be leukopenia, and the infection is also associated with multiple blood transfusion. The accumulation of iron takes place in different organs of the body. Deposition in pituitary will lead to the endocrine disturbance. This will further cause short stature, delayed puberty, poor secondary sexual characters. There will be hematochromatosis. This will lead to the cirrhosis of liver. If accumulation takes place in the cardiac muscles, there will be cardiac hemosiderosis. This will cause cardiac failure, arrhythmia, heart block, atrial pericarditis. Deposition in pancreas will cause diabetes mellitus. There will be adrenal insufficiency, hypothyroidism, hypoparathyroidism. In the lungs, there will be restrictive lung defects. There will be increased susceptibility to infections, especially Yersinia infections. The iron favors its growth. Clinical features of thalassemia measure in infants. The age of presentation will be 6 to 9 months when HbF replaced by Hba. There will be progressive pallor and jaundice, cardiac failure, failure to thrive, gross motor delay, feeding problems, bouts of fever and diarrhea, and there will be hepatosplenomegaly. By childhood, there will be growth retardation. The severe anemia will cause cardiac dilatation. The patient will be transfusion dependent. There will be icterus, and there are different changes in skeletal system. Skeletal changes are the major feature of thalassemia. There will be chipmunk facies, also called hemolytic facies. There will be frontal washing, maxillary hypertrophy, depression of nasal bridge, malocclusion of teeth. There will be paravertebral masses. This is due to the broad expansion of ribs at vertebral attachment. There will be paraparesis. The pathological fractures may be due to the cortical thinning, increased porosity of long bones. There will be delayed pneumatization of sinuses. The short stature will take place due to the premature fusion of epiphysis. Other features will be delayed menarche, gallstones, leg ulcers, pericarditis, diabetes, cirrhosis of liver, and evidence of hypersplenism. In thalassemia intermedia, there will be moderate pallor, usually maintains hemoglobin more than 6 gram percentage. Anemia worsens with infections. The less transfusion dependent, there will be skeletal changes and progressive splenomegaly. There will be growth retardation. The survival of thalassemia intermedia will be more than the thalassemia major. Thalassemia minor patient will be asymptomatic. There will be mild pallor, no jaundice, no growth retardation, no skeletal abnormalities, no splenomegaly. May present as iron deficiency anemia. There will be hypochromic microcytic anemia, unresponsive, effective to iron therapy. There will be normal life. Now we shall discuss on the diagnosis of thalassemia. In blood picture, the hemoglobin will be reduced. It may go up to 3 to 9 mg per dl. RBC count will be increased. WBC platelets will be normal. RBC indices in which the MCV, MCH, MCSC will be reduced. In the peripheral blood smear, there will be microcytic hypochromic anemia, anisopoikilocytosis, target cells, nucleated RBC, leptocytes, basophilic stippling, teardrop cells. There will be cytoplasmic inclusion bodies, especially in the alpha thalassemia. In post-splenectomy cases, there will be Howell-Jolly and Henge bodies. Reticulocyte count may be increased, maybe up to 10%. This slide showing blood smear picture of thalassemia. Total bilirubin and indirect bilirubin will be increased. Serum ferrous ferritin level elevated. There will be transferrin saturation. In bone marrow study, we will find the feature of hyperplastic erythropoiesis. there will be decreased red cell survival. The folate levels will be concurrently decreased. The normal free erythrocyte porphyrin, the serum uric acid will be raised, and there will be hemocysteine in urine. Because iron is deposited in different organs of the body, so the iron overload can be assessed by following investigations: serum ferritin, urinary ferrous excretion, liver biopsy, chemical analysis of tissue ferrous, endomyocardial biopsies, myocardial MRI indexes. Ventricular function can be assessed by echo and ECG. Radiological changes in thalassemia. The earliest bony change will take place in small bones, especially of hand. There will be rectangular appearance. Medullary portion of bone is widened and bony cortex thinned out with coarse trabecular pattern in medulla. In skull, there will be widened diploic spaces. Interrupted porous gives hair on end appearance. Delayed pneumatization of sinuses. There will be maxilla appears overgrown with prominent malar eminences. Here in X-ray skull, we can see the hair on end appearance or crew cut appearance. Hemoglobin electrophoresis is an important tool in the diagnosis of thalassemia. In thalassemia measure, the hemoglobin F will be 98%, hemoglobin A2 will be 2%. The table below showing the level of different hemoglobin in major, minor and normal cases. Now we will talk about the treatment. There will be regular blood transfusion at 4 to 6 weeks interval to maintain the hemoglobin at 9.5 gram per dl and above. Only packed RBC are transfused. The 10 to 15 ml per kg of PRBC raises hemoglobin by 3 to 5 gram per dl. There may be neocyte transfusion also. If regular transfusion, there will be no hepatomegaly, no abnormal phases, but result in iron overload. Iron overload is a major cause of morbidity and mortality in thalassemia. So it can be treated by different iron chelators. These are desferoxamine, a parenteral chelator, DEFERIPRONE and deferacirox, both are oral iron chelators. Let's talk about desferoxamine. Iron chelating agents, desferoxamine, dose is 30 to 60 mg per kg per day. Intravenous / subcutaneous infusion pump over 12-hour period, 5 to 6 days per week. Start when ferritin level is more than 1000 nanogram per ml. Best more than 5 years of age. Vitamin C 200 mg on day of chelation. It will enhance DFO induced urinary excretion of iron. Adverse effects of desferoxamine. Cardiac toxicity will lead to arrhythmia in eyes, cataract, ears, sensory neural hearing loss, bone dysplasia, growth retardation. Rapid infusion will lead to histamine related reaction, hypotension, erythema, pruritus. It will also cause infection, sepsis. Oral iron chelators, DEFERIPRONE, dose is 40 to 100 mg per kg per day. Adverse effects: reversible arthropathy, drug-induced lupus, agranulocytosis. Other oral chelators is deferacirox, dose is 20 to 30 mg per kg once daily. Adverse effects are GIT upset, rashes, and raised serum creatinine. Other oral chelators are deprothiocin, pyridoxine, ICL 670. This removes ferrous from myocardial cells. Other mode of treatment is splenectomy. It should be deferred as long as possible, at least till 5 to 6 years of age. Indications are massive splenomegaly causing mechanical discomfort, progressively increasing blood transfusion requirements, more than 180 to 200 ml per kg per year, packed RBC. Definitive treatment of thalassemia is bone marrow transplantation. This is the best method for the cure, but the risk factors are hepatomegaly, more than 2 cm, portal fibrosis, iron overload, and older age. There are some newer therapies are in pipelines. We can do gene manipulation and replacement. By this method we can remove defective beta genes and stimulate gamma genes. We can use 5-azacitidine that increases gamma gene synthesis. We can augment HbF by certain drugs like hydroxyurea, myelin, butyrate derivatives, erythropoietin in thalassemia intermedia. Other supportive measures are tea that contains theanine and tannin that chelate iron. We can use vitamin C that increases iron excretion. We can restrict ferrous intake by decreasing meat, liver, spinach consumption. We can give folate in the dose of 1 mg per day. We can do genetic counseling. We can give psychological support. We can give hormonal therapy. In hormone therapy, we can give growth hormone, estrogen, testosterone, L-thyroxine. We can treat the CCF, a toxic effect of the deposition of iron in cardiac muscle. Prognosis should be explained to the attendant. Life expectancy is only 15 to 25 years. If the patient is untreated, the life expectancy is less than 5 years. Thalassemia can be prevented by doing antenatal diagnosis. That will be discussed in the next slide. We can think about the termination of pregnancy if there is a thalassemia measure. We can prevent marriage if both the partners are suspected of thalassemic trait. Prenatal diagnosis is done by following measures. If beta-alpha ratio is less than 0.025 in fetal blood, then we can think about the thalassemia measure. We can do chorionic villus biopsy at 10 to 12 weeks. We can go for amniocentesis at 15 to 18th week gestation. We can analyze of fetal DNA also. We can detect beta globin gene by PCR. In thalassemia minor oblique trait, hemoglobin will be normal or mildly reduced. MCH, MCV reduced. In peripheral blood smear, there will be anisopoikilocytosis, microcytosis, hypochromia, target cells. Serum bilirubin will be normal or mildly raised. In hemoglobin electrophoresis, there will be HbA2 3.5 to 7%, HbA 90 to 95%, HbF 1 to 5%. There will be moderate reduction of beta chain synthesis. Here, counseling is more important than treatment. Treatment is usually not required. Now we shall discuss in brief about the diagnosis and treatment of alpha thalassemia. Diagnosis is done by complete blood count, peripheral smear examination, and bone marrow study. Henge body in the HBS disease can be detected by brilliant gracile blue stain. Hemoglobin electrophoresis is done for HbH and Hb bars. Alpha-beta chain ratio will be decreased. Treatment of alpha thalassemia generally not required. Blood transfusion, iron chelation therapy for transfusion dependent cases. Oxygen drugs should be avoided. Infection should be treated aggressively. There should be given folic acid supplementation. Splenectomy is the other mode of treatment. Bone marrow transplantation and gene therapy are the definitive treatments. Thanks for your attention.